What are the associated symptoms? Is there tinnitus, pressure in the ear, loss of hearing sensation? Are there other central nervous system abnormalities, other neurological deficits? Are there any cardiovascular diseases? All these together can allow us to filter the symptoms into different compartments, and actually we can see the vertigo into different causes and different types using this approach. What are the clues in the history of a patient for obtaining a proper diagnosis? In BPPV, the vertigo is episodic and lasts for a few seconds, and it is associated with the position of the head or body, particularly a change of position of the head in relation to the body precipitates the vertigo. In inner ear diseases, sudden onset vertigo, and patient clearly remembers on what particular day, at what particular time the vertigo started. There will be associated hearing loss, there will be pressure in the ear, pressure sensation in the ear, there will be tinnitus, loud ringing noises in the ear. In Meniere's disease and vestibular neuronitis, vertigo lasts for hours and days. In CNS or cardiac or systemic diseases, the vertigo onset is very gradual and very ill-defined. Patient may not remember from which particular day he is unwell because of vertigo. There will be multiple neurological and cardiac signs. In cerebrovascular disease, like TIA, like basilar artery migraine, like VBI, we have the onset acute and very sudden. There will be sudden neurological deficit. Cerebrovascular risk factors will be present in addition to sudden onset of vertigo. In a patient of central vertigo, due to brainstem causes, we have an array of neurological findings like diplopia, dysarthria, dysphagia, weakness of muscles, weakness of one or more limbs, unable to walk, in addition to autonomic symptoms, nausea, etc. In cerebellar ataxia, in cerebellar vertigo, we have ataxia, dysdiadochokinesis, and other cerebellar signs. In Meniere's disease, there is hearing loss associated with vertigo. There will be sensation of pressure in the ear. There will be tinnitus, and the disease is always progressive. In vestibular neuronitis, there is a history of upper respiratory infection. There will be viral illness preceding the vertigo, and there will be sensory changes in the segments C2 and C3. Remember, patient of vestibular neuronitis and labyrinthitis recovers much faster. In migraine, there will be associated migraine headaches, the aura of migraine associated with dizziness. It is important for us to differentiate vertigo due to central causes from the vertigo due to peripheral causes. Nystagmus is an important clinical sign in the assessment of vertigo. Electronystagmography is a tool to clearly record and analyze the nystagmus. Nystagmus has to be analyzed in terms of the spontaneity or gauge induced or not, the positional nature of the nystagmus, and also we should see whether it is associated with nausea, autonomic symptoms. Is it horizontal, vertical, rotatory, and what is the latency of the nystagmus occurrence after a change in the position? Is there a failure of fixation of suppression of the nystagmus? Is the nystagmus fatigable by repeated testing? These are important aspects which we have to see. The other important test for vestibular function is the caloric testing. In caloric testing, 1 ml of water at 30 degrees centigrade or 44 degrees centigrade, a cold caloric test or a warm caloric test 7 degrees from the body temperature on either side is chosen and injected into the inner each ear separately, and observed for nystagmus using Frengel's glasses. Frengel's glasses allow the patient not to fix his eyes on any object, so that the nystagmus can be viewed without any problem. Remember the acronym COWS. CO, cold opposite, WS, warm same side. Whenever we inject the cold water, a cold calorie test, the nystagmus will be towards the opposite side. When we inject warm water, the nystagmus will be to the same side. What is nystagmus? It is an involuntary rhythmic oscillation of the eyeballs. There will be a jerky fast phase followed by a slow return to the starting position. The direction of the nystagmus is described in terms of the fast phase. Electronystagmogram accurately records the nystagmus. Horizontal, vertical, torsional or rotatory types can be observed. It occurs in around 10 to 40 seconds after the head movement in a case of BPPV. Fatigability of the nystagmus always indicates it is the vertigo is due to a peripheral cause. These pictures show the nystagmus testing headgears. Frenzel's lenses are 20 diopter plus lenses. When the patient views through these lenses, he cannot see anything opposite to him, so much so he cannot fix his vision on any particular object opposite his eye, and so the nystagmus is not obstructed, and we can clearly record and see the nystagmus when we use the Frenzel's lenses. Computerized video recording of the nystagmus by ENG is far superior than just using Frenzel's lenses and observing for nystagmus. Vestibular function testing is important in clinical practice. Vestibulospinal reflexes can be tested by using tandem gait, Romberg's test for equilibrium and proprioception, and Fukuda stepping test. Hamid vestibular stress test, the sensory component, the HCFP, and the motor component, the body impulse test, also test the intactness of the vestibular apparatus. Hyperventilation test is also important. Now I shall demonstrate to you how these tests are done. And once you understand how these tests are done, it's very simple for us to apply them in clinical practice. What is the routine test protocol for assessing a case of vertigo? A thorough clinical examination for all central causes, CNS examination in particular, examination for postural hypotension, clinical tests of balance as described earlier, complete neurocardiovascular examination, of course complete blood count and ESR, ECG with rhythm strip for arrhythmias, CV risk factor assessment, cervical spine evaluation for cervical spondylosis and cervical spinal involvement, of course pure tone audiometry to test the hearing, and of course special vestibular tests to assess vestibular function are important. In addition, some unusual cases and some cases where the diagnosis is not clear, by doing this above test may require MRI and MRA, that is magnetic resonance imaging and magnetic resonance angiography of the vestibulobasilar territory, particularly when we suspect VBI or basilar artery territory involvement. The special vestibular tests include VOR, vestibulo-ocular reflex test, which include again electronystagmography, ENG, optokinetic nystagmus OKN, saccadic test, gaze test, pursuit eye movement test, bithermal caloric test. In addition, positioning tests like Hall-Peck positioning test for BPPV, computerized dynamic postulography on a computerized platform to assess the stability of the posture, that is the CDP, and the rotating chair test, also called the SHA. It's called SHA because sinusoidal harmonic acceleration test. And these tests tell us about whether it is a central vertigo or a peripheral vertigo, whether it is one-sided involvement or two-sided involvement, whether there is an associated hearing impairment also. On the left you see the stop sign. This stop road sign is seen in a shaky manner by a person who is having oscillopsia. Oscillopsia is oscillation of the eyeballs. This occurs when there is a bilateral vestibular deficit. On the right side you see a chair with striped balls all round, and when the woman rotates, due to the rotation of the chair, there will be optokinetic effect will be introduced, and optokinetic nystagmus will be elicited. And then the rotatory chair test is important to test for bilateral vestibular deficit. As we have discussed, the disorders of balance fall into four main categories. 50% of the patients are due to vertigo. About 25% of the patients, the symptoms are due to syncope. Another 15% of the patients, it is due to the ataxia or due to the proprioceptive impulses failure. And about 10% of the patients, it is due to the psychogenic causes. When we eliminate syncope, when we eliminate ataxia, when we eliminate psychogenic causes, we are left with the entity called vertigo or the true vertigo. The fundamental question is it due to a central lesion in the pathways that connect the vestibular apparatus to the brain, or is it due to the vestibular apparatus per se, which is called the peripheral? This distinction of central vertigo versus peripheral is highly important to plan the treatment and to give the prognosis. How to differentiate central from peripheral vertigo? Nystagmus gives us the clue. The type of nystagmus, the latency, the fatigability, the habituation, the intensity of the nystagmus, the reproducibility, the vestibulo-ocular reflexes, the vestibulospinal reflexes and gait, and the neurological findings. In peripheral vertigo, the nystagmus is rotatory, latency of 3 to 40 seconds, it is fatigable, it is habituable, intensity is very severe, reproducibility variable, and it is related to the position, positional VOR, and gait is very cautious, as though he is walking on a wet floor. And there is associated loss of or impairment of hearing and associated tinnitus. In central vertigo, the nystagmus is not rotatory, it is either horizontal or vertical. The latency is immediate, it occurs immediately on assuming a particular position. There is no fatigability, there is no habituation, the intensity of the nystagmus is mild and it is very well reproducible. The VOR reflexes are hyperactive, the gait is wide-based gait, just like the cerebellar gait. And then, of course, you have the CNS findings or other brainstem findings. Peripheral vertigo is due to a defect of the vestibular apparatus or due to a lesion in the vestibular apparatus. The most common cause of vertigo is benign paroxysmal positional vertigo. Vestibular neuronitis, labyrinthitis, ototoxins, autoimmune diseases of the inner ear, Meniere's disease, all cause peripheral vertigo. In central vertigo,